Hello everyone, I am Dr. Deepsekhar, Assistant Professor of Ophthalmology at AIIMS, New Delhi. Today I will be talking about traumatic optic neuropathy. At the outset, I would like to congratulate the Young Ophthalmic Society of India for coming up with this brilliant initiative, and I would also like to thank them for giving me this opportunity to present. Traumatic optic neuropathy refers to any insult to the optic nerve secondary to trauma. It can be classified either on the basis of the site of injury into optic nerve head, intraorbital, intracanalicular or intracranial part, or it can be classified on the basis of the mode of injury into direct and indirect traumatic optic neuropathy. Common causes involve road traffic accidents, fall from height, physical assault, with or without penetrating foreign bodies, and sports injuries. Indirect traumatic optic neuropathy is a mechanical impact induced injury to the optic nerve that often results in partial or complete loss of visual function to one or both the eyes. So coming to an example, a 21-year-old male presented with history of pellet injury to the right eye 4 days back. At presentation, the vision was pale positive with PR accurate in the affected eye. There was relative afferent pupillary defect. X-ray revealed a fragmented pellet in the right orbit. A diagnosis of right eye traumatic optic neuropathy was made. The patient was started on steroids and the visual acuity improved to 6/6 at 2 weeks follow-up. In contrast to indirect traumatic optic neuropathy, direct traumatic optic neuropathy is a condition in which a fragment from a fracture of the skull or a penetrating foreign body directly damages the optic nerve. So here is an example. A 32-year-old male presented with the history of road traffic accident. At presentation, the vision was pale positive in the left eye. A foreign body was noted in the medial aspect of the left orbit. CT scan revealed a large organic foreign body with fracture of the optic canal on the left side. A diagnosis of left orbital foreign body with traumatic optic neuropathy was made. The patient underwent surgery with the removal of the foreign body. However, as the optic nerve was avulsed, the vision in the left eye did not recover. In the left side, you can see the images with the blue arrows pointing towards the foreign body and the red arrow indicating the fracture of the optic canal. Coming to primary management, it involves initial assessment and certain initial investigations. As these are patients who had a history of trauma, it is of utmost importance to have a thorough general examination of mainly the vitals, namely pulse, blood pressure and systemic examination, also the cognition. Local examination to also be done to look for orbital fractures, orbital emphysema, extraocular movements, visual acuity, pupillary reactions and intraocular trauma, orbital injury or any foreign body. Initial investigation should in getting an X-ray PNS and orbit at the earliest, a neuroimaging, that is a CT scan for locating fractures. Once metallic foreign body has been ruled out, a contrast enhanced MRI of the brain and orbit can be advised. Visual evoked response, visual fields, color and contrast should also be done to rule out optic nerve damage. At the initial point of contact, one should also look for certain important prognostic factors, namely in cases of indirect traumatic optic neuropathy, loss of consciousness, optic canal fracture, absence of visual evoked response, and absence of any visual recovery at 48 hours are extremely poor prognostic factors. In direct traumatic optic neuropathy, most cases are always associated with poor visual prognosis. Treatment options include intravenous steroids, surgery and a combination of both steroid with surgery. So coming to intravenous steroids, as per the National Acute Spinal Cord Injury Study Group, one must initiate the treatment within 8 hours of injury, where an initial bolus dose of 30 mg per kg has to be infused, followed by 5.4 mg per kg per hour over 23 hours. Surgery mainly involves around intracranial and extracranial approaches of optic nerve decompression. However, the timing of surgery and the implication of the surgical procedure still remains a debatable topic. When surgery is combined with steroid therapy, certain regimens of steroid have been used that includes low dose steroids, moderate dose steroids, high dose, very high dose, and mega dose of methylprednisolone. Talking about few more related studies which have been performed in the past, the International Optic Nerve Trauma Study had revealed that patients with indirect traumatic optic neuropathy, if left untreated, had similar results to that of giving steroids, and in fact it's better than that of patients undergoing surgical decompression. Third, National Acute Spinal Cord Injury Study Group revealed that patients who received steroids within 3 to 8 hours after the injury experienced better motor and functional recovery within this regimen when the regimen was maintained for 48 hours instead of 24 hours. Thank you.